right, good afternoon, everyone. Eva Hussein from Polaron Language Services here, welcoming you from a pretty wet and miserable Melbourne. Jolyon told me not to tell you, but it is true. The weather's been a bit today, but never mind, we're here. And today we're going to be having a roundtable discussion about making health information easier to understand. And with that, I have a couple of very special guests to introduce to you. We have Harry Field, our NAATI certified Greek interpreter. Hello, Harry.
Hello, Eva.
We also have, good to see you. And I hear that the weather's much better in Sydney. Is that right?
Yes, 30 degrees and sunny.
Very nice, very jealous here. I'd also like to introduce to you Jolyon Burford, who's from CH, so that's Centre for Culture, Ethnicity and Health. He is the health literacy trainer, and I've worked with Jolyon on a number of different projects and a number of different occasions. And also David Chal, who's the health promotion engagement from Access HC. So good afternoon to you, Jolyon. Good afternoon to you, David.
Hello. Hey.
Hi. All right. So what's this about? What is it about literacy that's a problem? Why is it a problem? Why are we still talking about it end of 2020? David, I might hand over to you. But firstly, could you tell us a bit more about your organisation and what you do there, please?
Yeah, so Access Health Community is a community health service. We work in the inner east of Melbourne, and we've been around for about 150 years. We have general practice, primary care, dental, mental health, AOD, community programs, neighbourhood houses. So we've got about 16 sites and about 330 staff across the east of Melbourne.
Right. So that sounds like a very big portfolio, and it sounds to me also like communication and dissemination of information is something that's very high on your agenda. Have you noticed that things are improving, or again, going back to my original point, why are we still talking about it?
I think things are improving. Slowly but surely, I think things are improving. I think people are becoming more cognizant of the fact that even English-speaking Australians do not understand health information that's given to them, and just because you translate something into another language, whatever means you might choose to do that, doesn't mean that the end recipient is going to understand it either. But there's still a long way to go. Health information is still often designed by the people who know the most, and health information can often be very protective of the people who hold the power in that situation.
And Jolyon, could I ask you to contribute at this point, firstly by telling us what you do and more about the organisation you represent, because you have made it your business to make information more accessible.
Yeah, I would agree with David that there's definitely movement, because I see just even the formatting of information is getting better with these new kind of websites that templates and such. But I think that David and I probably both have a job for a while yet. So I'm Jolyon, and I'm a trainer in health literacy and cultural competence at the Centre for Culture, Ethnicity and Health. And we're really kind of interested in anything that allows people to become more in control of their own health, or help organizations to make sure that they're communicating in a way that everyone can understand. And there's a whole bunch of stuff there around organizational processes and on an individual level for workers, that kind of stuff. But that's my rambly first comment for the day.
That makes sense. That makes sense. Speaking of rambly comments, I'll ask Harry to contribute, because Harry, you've been a translator how many years?
I've been a translator for 35 years, but I have also worked as a in the area of multicultural services with Centrelink for 20 years. I'm left now. So I have the perspective from both the practitioner and let's say the policy sort of view. And my view is, firstly, it's in terms of translation, I'm talking more specifically here, it's the quality of the text. As we had a previous discussion with the other panel members, it must be written by persons with professional or very good communication skills, not by experts, unless they have the same skills. Because you have a difficulty trying to, you don't have a lot of flexibility in trying to change what is written. Sometimes it's good to have explanatory information for when you do translation or similar other work. And in translation terms, all the medical or medical translation work must be checked, I think, I believe.
By a second person. And given that you're in this area for quite some time, so 35 years is a long time, are you seeing changes? Are things improving, do you think?
Well, yes, it is improving in terms of, I think, better understanding from the relevant departments. And there is more expertise, but sometimes it seems to me that the expertise is not very consistent in some departments. That is, you have a lot of movements of people who probably take away their experience, but there is an improvement overall in terms of quantity and quality as well. Yeah.
And David, can I ask you, given the catchment area and the region of Melbourne that you cover, how much translated information do you produce, or how do you produce it, or how do you know whether it's of good quality? And what is good quality in translation anyway?
I mean, we rely on having good or well-translated information by using qualified translation services like Polaron to translate information for us. We also use community translation with some of our culturally specific community groups to translate information so that it's relevant and accessible to them. I would say that we have insufficient amounts of information translated, and that we could do a lot more. So we have an automatic translation facility on our website, but it's that kind of clunky Google Translate situation, which we all know is fine for very defined pieces of information, but not great when something's stretching out as long as a sentence. We've certainly commenced through COVID translating large parts of our primary client information into the 6 most common community languages that we have, and that's extended into some other COVID specific projects because we know that people need accurate, real-time information that is relevant to Melbourne and relevant to their situation in the language that they understand.
And you did say that potentially there's not enough information translated. Do you think it's the quantity or the quality that matters? And I also was going to ask you about perhaps the smaller communities that are not so big in numbers, but probably quite high in need. How would you address their needs in terms of receiving information that you've mentioned that's essential at this time?
And I guess it's also, we often have the sense that we're really just talking about written translation, and we've got lots of communities. To be fair, not as many that we work in with our catchment, but we have communities where their language is not written, and so we have to provide opportunities for people in that space as well. We have access to interpreters, and we can arrange interpreters in relatively short periods of time if we require them. But I absolutely think that we could be doing more we ask all of our clients and patients at intake about the language that they most commonly speak, and we take steps to try and involve interpreters or translated materials through that process. But it's also important for a lot of our work where we, if we're discussing a document with a client, that it isn't just a translated version, but we actually provide an English and translated version together so that the staff member or clinician actually knows what they're explaining when they're taking the person through a document.
And have you found in the last, say, 6 months that you've had to be more creative and more resourceful in how that that information is not just developed but presented to your clients or people that you work with?
I think certainly in COVID we've known that people have needed information much quicker, and so generally, maybe only our privacy statements or rights and responsibilities brochures or service brochures or those sorts of things would have been translated fairly uniformly. But it's the first time that we've ever had translated materials on our social media feeds, for example. We've had to turn that around really quickly to make sure that that was there, or to we found very early on in COVID that people were either not understanding that we needed to ask them screening questions, or they were actively choosing to not tell the truth when we were screening them. And we got some feedback that people were getting a bit sick of the no, stop, don't kind of messaging. And so we reframed all of our risk information into more altruistic kind of language about that it's really important if you, and would you please, and then we translated that into community languages.
Mm-hmm.
So shifting it away from being a much harsher message, and that seemed to work better for people as well.
So interesting.
Sorry.
Yeah, go.
Sorry, David. Yeah, can you just tell me, like, how did you come to have those conversations? Was there a formal process, or was that just what you heard back from staff, or how did you gather that information?
It was primarily investigations into incidents when we would have people go through 3 or 4 screening tests, on the phone when they get to reception, when they book the appointment, all of these sorts of things. And then they sit down in front of the clinician. The clinician says, "Oh, how are you today?" And they say, "Oh, I've got a bit of a cough." And she's like, "We've asked you 3 times in the last 24 hours whether you have a cough, and now you're telling." And so going through that, "Oh, why didn't you? Oh, I didn't really think it was that important. I know it's not COVID," these kind of things. So that caused us to shift that language towards people be aware of values-based messaging. So, just adjusting that language so that it suited people better.
Right. And Jolene, as a trainer in the plain language space, and I know that you also do a lot of training in the space of how to work with interpreters, how to develop translated materials. What sort of advice would you give those of us that aren't I guess the word is knowledgeable? Can you give us a few tips of how to do it?
I mean, the main thing I think is that, like, with any health literacy situation, so I come from an education background. The idea of multi-literacies is one that comes from education, and it's like reading posters is a form of literacy. Like, if you've never seen a poster before, you don't understand what posters do, then you're missing some context, and so you don't know how to do that. Health is the same. Specific health information is the same. You need a set of skills and you need some knowledge to be able to do that. And so really what we're trying to do here is kind of weigh up, like, what are we asking that person to understand if they're to understand our message? And so when we've got a general audience, a very general audience that we don't know much about, the general rule is that we just are going to simplify it, but we're still going to get our message across, but we are going to simplify it as much as possible and reduce the amount of information. Like, we're really looking at, how do we get this message across to this person? What's important? What can we get rid of? Because, if someone's faced with an enormous document, or like all these niceties, it's 3 pages long, they get lost if they're not a good reader. So the people who are good readers will work through something and find out what you're trying to say and be able to do it. People who are not good readers will struggle. So the less you're asking people to do, the better. And, you know, it's that need to know versus nice to know is really key.
Harry, can I bring you into the conversation here at this point? Because what I've often wondered about plain language, plain English, when it's translated into other languages like Polish, for example, which is my native language, is whether it can sound a little bit patronizing. How do you balance simplicity with politeness and just the right register when you translate things?
Well, it's a cultural thing, of course. So you have to sort of think about what they're trying to say and try to make a balance that you give the right, you give also the right message as well. So it depends how it's written, and you have to be you have to think through a lot how to do it. But I think there is a role of, like your companies, I think, or translation companies, they have to educate and inform the clients about how to go about producing multilingual information, whether it's for translation, for radio, or for video. And one of the good things I've seen with COVID is I've never seen such a variety of information being developed in this very digital media, which is good. But it comes back to the original message, I think, what you want to do. And it's up to the translator or to the other linguist to, depending on his knowledge of culture and the context here, to adjust or whatever you have to do. For instance, in Greece, translations tend to be a little bit, rather information tends to be a little bit more formal than here. Here sometimes it can be the other extreme, so it's a little bit trickier.
Yeah. So it's that fine balance. But you did mention checking of your translations or having a feedback loop. And I know that some translators get very upset when they receive feedback because sometimes it might not be justified. How do you work with another colleague to strike that balance? Because, you know, at the end of the day, it's a community that's going to read your information. And your health message is not just so that you can put it up on a wall somewhere. It actually is going to be used by humans, right? So what are some of the tips, or what are some of the challenges of working with another colleague in the same language pair as a translator who works with you to produce a translation that should be of better quality than if there was just you?
Yeah. Well, my aim is basically to get the best possible final product out. Let's put it this way. So even if there is something that I think it looks good, it makes sense, if the other person comes with something which a little bit, although it doesn't make a lot of difference, but it's better, then I will accept it. And sometimes, so that's my principle. It's what I want to have the best possible end product. So even if I have things that are marginally different, but the other suggestion is better, it's good. It also depends on the checker and the translator and the checker, because some checkers are more sort of flexible, so others are more sort of picky. But at the end is I think that the basic thing is what you want to produce at the end of the day, and it's something that somebody reads it and understands it very well, and I think that's my guiding principle always.
And now I have another question to the panel. I might start with you, David. Do you think that the pandemic, COVID-19, has changed the way that we consume information, and how much of it has actually made it into diverse communities in your service, in the area that you're working?
Well, I think we were all hanging out in Victoria for 11:30 every day to get the update from the Premier, and in other states it happened at other times, and people would set their routine around when the daily briefing was going to be and what the outcome and the impact would be. But I wonder what your experience was if you weren't either English speaking or sign language, because if you spoke another language, you probably weren't necessarily picking up information from that. And so your experience would have been very different, because you could have probably been doing something else at that time of the day. I think people, more and more, they want information quickly, and they want to understand the impact that information will have on them. And I think COVID has done that more. I think it's just sort of increased that. We received reusable masks from the government as a community health service, thousands and thousands of reusable masks, which were very easy for us to disseminate to people in the community who needed them. But the information that came with them was complex, small font, very wordy, so very quickly we had to turn that information around, simplify it right down to what do you need to do with a reusable mask? You need to wear it, you need to wash it, you need to dry it. And that's all you need to know. You don't need to know who funded it or where it came from or all of these other sorts of bits and pieces. And you need that in really clear and simple information, which is warm for the person to read, because you don't want it to be too clinical and too callous, because you want the person to adopt the behaviour associated with the messaging as well. But that does mean that there's an inequity, because we can turn that information around much quicker for someone who speaks English and reads English well, than someone who, and indeed, if we've got staff in our organisation who are comfortable translating information at a good enough standard that we could use it at least for a short period of time. But if you're from a language where we don't have coverage, then you're going to have to wait longer for that information.
And I think I'm so pleased that you mentioned these points, because as COVID, the initial wave was kind of rolling out in Melbourne, I had an idea of grabbing 30 seconds of the Premier's speech and translating it into 300 languages. Of course, that's never happened because the idea just wasn't interesting to enough people, and I think there was an expectation that the community was going to do it for free, or that somehow yes, we need to fund a sign language interpreter, but other languages don't matter. So that I guess that provided for an extra level of isolation for people, or lack of information, confusion, all of that. And I think that also contributes to health outcomes and mental health issues, and I think we will still see those issues for months, if not years to come. Jolene, what about you? What do you think about this idea that the way we communicate is changing? Are you seeing that through your service? Are you seeing that through people that you train?
When are you talking about, so the avenues through which you put out information? Yeah, I mean, I think, I personally prefer video. I watch video for everything. And, as soon as I see, this was hard when I was studying, but as soon as I see a table, it's I immediately want to go to sleep. And I think if you show a table to 30% of the population, have the same response. And so while the people who are in the kind of positions who create knowledge generally and push it out to communities are used to typing, the people who, the communities that need to use that information probably want it in a different way. And increasingly what we're seeing is that there's lots of different ways that different communities have different ways that they want to receive information, be it through a particular app, or a particular social media platform. And I think it's just really that changing to provide information in the way that people want it, and also the information that people want, because there's no point in going through all that trouble, and it's a lot of work to do it well, and then you haven't, the people are not interested in what you're selling. Yeah.
I think the governments, and not just in Australia, but they copped, and rightly so, a lot of flack for assuming that they should translate a whole heap of things, put it on their website, and people will somehow find it. What are better ways of looking for information, or not looking for information, but presenting information to the community? And I think both of you, Jillian and David, mentioned that you know, having that grassroots community involvement and not just translating things that no one's going to read is the way to go. But any other ideas of how to not just develop the information but present it to the community that is actually useful?
I think there's interesting models like sort of community connector models and things like that. There are, you know, there are those people in your local neighbourhood who, when a young mum moves in, you know, at number 17, they'll go past the maternal and child health centre and pick up a wodge of brochures and just drop them off in case she wants that information. There are these kind of, you know, often they're termed mavens who collect and altruistically disseminate information. And if you can find those people in your local communities, they are the best way to get information out. You know, and holding regular engagement with those kind of mavens for information, with those community connectors. I think that's a really powerful way to appropriately communicate. You want the people who are communicating with others for absolutely no benefit to themselves. And those people are out there.
Mm-hmm. And I know that, for example, when the towers in Melbourne were locked down, there were people in the towers translating information, text messages, WhatsApp, WeChat, whatever they could get their hands on. And of course, there was a community response. But for me, what was disappointing was the fact that nobody thought of producing that information through professional channels. And given that a lot of interpreters, for example, were with no work at that point, because the number of interpreting sessions have dropped down to something like, you know, 5% of normal levels, that there's still lack of coordination in the system, I guess, to some extent. And I was hoping that, Jillian, you could talk to that a little bit, because I know that CEH, on top of what you do, have the health translations directory and other initiatives that are hopefully slowly starting to make way, you know, into service providers. But would you just give us a bit of insight of what happens at your end, at your organisation?
Well, I mean, I just want to say, like, what I mean, what David's kind of describing is like an organizational, you know, response where you're planning to engage those people, to identify, engage, support those people. And so, I mean, firstly, I'll just say that organizations that are thinking in that way and not just leaving that to chance. I think Harry was speaking about this before, is like not just kind of, you know, there's someone who's very motivated, who's very connected with the community, and that person then moves on, and then you're back to where you were. You maybe don't have those connections. All those things need to be reformed. So from a health literacy perspective, it's very clear that those kind of organizational responses are indeed like the way to go. In terms of the health translations website, yeah, we have just consistently talked about that in every single training, every single thing that we have that we ever hold. We tend to talk about health translations, and you've raised it, so that's good that I didn't have to. My colleagues work incredibly hard on that to make sure all the links are live. Make sure that there is an English version that practitioners can look at to make sure that they're giving people good quality information. And yeah, I mean, the amount of traffic has like something like up 500% or something over a year. So, I mean, they're doing a great job. I'm not sure if I'm answering your question.
You are. And I think it's not just Australians that, I think we had Annie from the organisation tell us that it's such a great website that people from all over the world come to it, knowing that the information will be not just accessible, but relevant and accurate. And I think you put a lot of work into making sure that that's the case, yeah?
David?
Yeah, I think there's I think to your point, Eva, around, why people didn't use professional translation services. I think there's a misconception about the time that it can take for translations to be performed, and also a misconception around the cost. Genuinely, people will say, "Oh, we don't have time for that," or "Oh, that's going to be very expensive for us to translate that." That's not our experience, but I would say that we're still fairly infantile in our approach to it. Finding ways in which you can provide translated information quickly and economically, it's totally possible. It's just there's a bit of a historical misconception out there.
Mm-hmm. It's an excellent point. And I should also add here that, speaking of economics, not providing information in a way that people can understand and use is much more costly than doing so. And I think, you don't need to translate the entire website. You can chunk the information. And I think some of the tips that we've been giving to our audience is precisely that simplify it. Instead of 1,000 words, do 100. And, that's simple, inexpensive, and easy to do. And especially if you've never done translation, give it a go at a smaller scale so that it's not such a big risk. Or such a big enterprise. But if you are not providing information to your multicultural whatever's communities, the cost of not doing so is probably much, much higher than the translation that you should be doing, is what I would say. Harry, you've been around, so I was going to ask you just a question about, this always gets people excited, about some bad translations that you may have seen in your time, and maybe you could give us a couple of examples.
About some?
Poor translations, yes.
Okay, but before I go to that, may I add one more point to
of course.
my previous speakers? I think now that the COVID is sort of more under control and departments don't feel a lot of pressure to produce things, it's important to make an assessment of that digital work, whether it's translation, radio, video. Because, for instance, like in the Greek community, where over 70% of the people are 65 years or old, and a lot of them are not computer literate or English literate, they will have to rely a lot on other people to access the information if they know it's there. And secondly, because of COVID, you couldn't use a lot of community organizations because of social distancing. So you have to see also, you have to make a post-assessment and see how this was actually used by the community. I think that's very important, and then you can move forward. Now, your question was if I had a bad translation.
Yes.
A bad translation that was actually published, or bad translation that I had?
Well, hopefully not. Hopefully you caught it right in time.
Well, look, we all have our days. So, of course, I had, 35 years, of course, I had bad translations. I don't think even now with COVID, there were some translations that I've done that they come back to me for updates. And especially if they, over, 1,000, 2,000 words. And I go again through them, although there may be, like, for instance, a small update to do. I'll go back, and then I can see that there is there can be some improvement. I don't think I have made a terrible one that has gone out, but obviously I have produced in my sort of working life translations that are not better, and especially when you see sometimes you get back, not sometimes, very rarely, a file which has about 50,000, track changes, which may not be there. So, but this is a learning experience as well. And of course, you try not to avoid it. But I think when you don't have a checker, sometimes you tend to be a little bit more, you tend to be a lot more careful than when you have one. That's my experience, subconsciously at least anyway.
Right.
But I haven't done anything wrong that, people have got completely wrong information and you have some financial impacts and all that. No,
Yeah.
not that bad.
But I think one of the interesting points you made is that, you know, at the outset, when COVID struck, everybody was translating everything for everybody, and we were running around. And you know, I remember even in Polish, where you know, like COVID, what's COVID? Is it with a V? Is it COVID-19? Like how do you, you know? So we ended up with lots of, I still think, confusing information that could do with a review, and you know, things like glossaries of terms are very important, and also reflecting on what worked and what didn't, which is what you've just said, I think, where you know, we had to do what we had to do at the time where people really needed information urgently. But now that things have come down, there should be a level of review and lessons learned from what happened. I'm going to hand over to Andrea now, though, for some questions, and we have a lot of questions. So thank you.
Can I? Sorry, can I just make one more point?
Of course.
I mean, from my perspective, so I mean, I spent like quite a while looking at plain language communication and looking through the research on the health literacy research on how to get people to understand your messages. And the one thing, the most common thing I see is that like people unnecessarily explaining stuff to people. Like, so let's say you've got a health concept. If you can get away with not at all talking about that jargon and just say what it is, like, oh, you've got a sore leg, your leg is hurting. If your leg is hurting, you know, like if you know, when you eat something, you don't feel good, you know, like don't just get rid of all of that crap. People don't care. And the people who are least able to understand it are the people who are most likely to get, you know, bad health outcomes when you do that kind of stuff. So really just think about, like, do you need to explain the genetic basis for Huntington's disease to someone? Or do you just need to say, look, if one of your parents has got it, you've got a 50% chance of getting it? Or do you need to explain, like, kind of, you know, genetics, like what is genetics? Or, you know, like, it's like, you know, just don't waste your time.
Yeah.
Yeah.
I so agree with you, because in fact, even people that have, you know, I guess you could call them educated or health literate. I mean, a lot of people just skim through, like nobody reads stuff. And I think if you want your message to resonate, you do need to simplify it and make it so that it actually hits the right spots. And I completely agree with you. And I think sometimes you can overcomplicate by wanting to explain everything, but it's a matter of really honing in on pertinent points that matter. So, and it's, you know, I mean, you're the trainer, I shouldn't tell you, but it's probably 3 messages at the most that you can put on a page, because everything else. And
the simplicity is really hard for health professionals because they've got all of this knowledge, you know, so much knowledge, and they think that people, you know, they need to give people as much informed consent as they can because that's what they're taught to do. But the awareness that sometimes the more information you give people, the more you confuse them.
And of course, yeah, go on.
I was just going to say, I had a situation where I had a bit of a crazy landlord a little while ago, and he wanted to take us through the court system for some reason. Anyway, that is another story. But this guy, so I called up Legal Aid, and I took notes of everything they said to me. They used a lot of words, they used a lot of concepts. I wrote everything down, and when I'd finished a 45-minute conversation, I got off the phone and I looked at the page, and I realized that I did not have the schema to understand how all that information fits together. And I think that's the situation that happens in health as well, is, you know, like the level of context that's required to piece that information together or understand what it is you have to do is incredibly complex.
Right, because language is just one element of what you need to know to understand the system, and you know, it's so easy to fall out of the system, I guess, when you know, everything's not very inclusive in how that information is presented to you. I'm going to hand over to Andrea now just for a few questions. We do have a lot, so over to you, Andrea.
Yes, thank you so much, guys. I just wanted to start with a comment that we received from Rosemary from Bolton Clark, which I think is fascinating. She just sharing with us a few steps that they are following to ensure health literacy principles are incorporated when translating resources. So basically, she shared the link to those steps. I'll try to share with all participants shortly, but basically she's telling us that they try to make sure these steps are followed. Do you think, guys, that this is something that could be implemented in all organizations? Something like Rosemary just shared with us?
So you're talking about steps in
Yeah, so
producing
basically,
information?
Yeah, I mean,
10 steps, yeah.
Rosemary's been working for a long time and getting has had some great successes in thinking about this kind of communicating with diverse communities. And I think certainly it's all very well to have people who are good at their job and thinking about how translations can happen so people can understand them and they're appropriate for communities. But if you're not kind of putting that into your systems and processes and making sure that those are followed, then, you know, like it's very easy for those that knowledge to leave, and then you're back to where you were 10 years ago all of a sudden if that person leaves.
I agree. I think it has to sit within, you know, within procedures, within processes that you're going to follow. You need to say, you know, all this information will always be translated, and you know, you need to make it quite clear and give a kind of compliance stick, if you like, to ensure that that occurs. Because otherwise, it's very easy to say, "Oh, I haven't got enough time."
We haven't got enough.
Oh, there's not quite enough money for this, and people are able to just find an excuse not to do it.
And of course, we've got all kinds of policies and governmental guidelines that are well-researched, well-written, and sometimes not followed. Over to you, Andrea.
Thank you. I have a question here from Yelling Hung from Healthcare Consumers Association, ACT. She's telling us there's so much health information and duplication out there, and this tends to confuse the community. Why health services can't reuse this information and make it available online, translated and spoken through this speaker technology in different languages?
David, can you just tell me about like how, because you know I've seen a number of initiatives where people are trying to work together, like hospitals working together to just make one document rather than, you know, every single hospital doing it themselves. What's it like as an organization trying to team up on resources and that kind of stuff?
Yeah, I mean, it is. Often it is very relational based. So if you've got a great relationship, not partnership, relationship with an individual at another organization, and you can pull lots of people who want to come together, and you know, you can absolutely have these outcomes. But the way in which health services and health systems are funded in Australia means that we are funded and measured individually, and we're never funded for partnership. We are always funded for delivery.
And you can see that as well. Like you see that occasionally there's funding for a period of years that act as a bridge between organizations, and then, you know, someone comes in who needs to save money, and then that's often, in my experience, that one of the first things to go.
It's not, you know, it's not putting a health professional in front of a person, and therefore it's backroom funding, and backroom funding is, you know, that kind of brokerage work is often the first stuff to go, and so it is absolutely not unusual to design this fantastic program which you think is really going to meet the needs of your community, then go and talk to another organisation about it, and they say, oh, those people in that neighbouring suburb, they're doing the exact same thing as you. and you have got no reference point to know that someone literally 10 kilometres away is planning the exact same thing because they come from a similar theoretical base, they're looking at the same evidence as you, and they're going to come up with the same intervention. And it's the same, you know, if you can imagine that that's occurring, then the same thing is going to occur as far as you know, translations and things are concerned. We should be working. I tried late last year to try and find an example of a really simplified privacy statement for a health service. Really simplified, really basic, because in the same respect, we have funders and accrediting organisations who will say, oh, you must include a statement about cross-border information flows, and you must include a statement about, no, someone just wants to know that the information that they're giving you is going to be safe and respected and protected. That's what people want to know.
Exactly.
But we have legal and accreditation and political frameworks which fly in the face of that all the time. Make it more difficult for us.
And I think given that the governments are the biggest purchasers of language services in Australia, and they are the ones that give us the money to produce translations, maybe there's a bit of lack of transparency, or we don't even know. It's not measured. So I know that every couple of years somebody does a review. They write a report, then it gets buried under somebody's carpet, and we're back to square one. So I think it's as much as you know, about money as the and how it's used, and how those relationships that you, David, mentioned are built, and how we talk to each other, because some of it is even political, and it's certainly confusing in terms of how the funding's allocated for what and how we can work together. Andrea, any other questions?
Yes. Why health government have to keep using so difficult language? They don't seem to get the message. How can we change the public servant mentality to be in the shoes of people for once?
Can I just say, finding people who are self-reflective is like the hardest thing in the world. And so if you want to, I mean, as soon as you've got more than 10 roles that require self-reflection, you're going to have trouble filling those roles. And then when you think about an entire class of people who have gone through university and been educated to write in a sophisticated way, it's like they're trained in exactly the opposite of what they need in order to communicate with everyday people. So, I mean, I personally would like to see, you know, large chunks of university where people are marked on whether or not they're writing it in plain language, and differentiating between audiences, the general audience, and you know, potentially what they have to do within their organization. But even then, you know, when I get something from my organization which is long and boring, I just don't read it, you know, like, and, you know, that's the reality of information exchange, isn't it? Too long, didn't read.
And I mean, I'm very passionate about this, but I'm just as guilty as
Yeah.
anyone. If I have to prepare a document about an area that I'm really knowledgeable about, I'll want to tell everyone about, you know, Krugman's prevention paradox, and why it's really important that we fund the prevention of intoxication, not the prevention of dependence. No one needs to know that. No, only I need to know that. And I mean, the issue of the way in which we train health professionals, the level that we're coming from. Universities, when they perform research, have something called a plain language statement. And it is one of the least plain language things you've ever come across in your life. It's incredible. And it's very hard to waver away from that, because there's a need to say everything to be considered to be ethical and complete, but a lack of realization that people are not going to read that. They're just going to sign their life away, which surely is not ethical.
But I think there is a strong move. I mean, certainly when people come to us for translation, we tell them not to translate some things because we know that people aren't going to be able to read it, or it's written in such a complex way that a translator needs to make it sound meaningless in another language, right? So I think it's important, and I think Harry's already mentioned that translators and service providers, you know, call this out and you know, work with the health industry, with health professionals on trying to do it better and raise the bar. Andrea, any other questions?
Yes, thank you. How do you think we could merge both accuracy and speed when translating resources?
That might be a question for you, Harry.
How can you match accuracy and speed?
Yeah.
With,
how can you merge both accuracy and speed when translating resources?
Well, first of all, it's a matter of skill, experience, having the correct tools, and try to have as little as possible a trade-off between what you do. I mean, there's no specific formula, but I think experience, skill, understanding of the context, it's individual, I think, to a large extent. It was interesting, a few weeks ago, I was at the webinar of OSIT, the Australian and the Australian Interpreters and Translators Organization, and there was a research shown that 90%, I think that was done by the University of Macquarie in Sydney, 90% of translators, they use Google Translate. Now, they don't rely on this to do a whole translation, but they rely to make references and all that. So obviously, technology plays a big part now in that. And I think it has impacted on translators because I think companies or other people know that you can have access to this information, so the timelines somehow are stricter, tighter in order to produce things. So it's a complicated thing, but I think you have to use your own experience and capacity to work through that. I mean, use as many tools as you like. I mean, sometimes I have to use Google Translate, specialist dictionaries, or sometimes I look on the internet about if this expression is used in my country of origin, how it's used. So you have different methods to approach it.
Yeah, it's a pretty complex question, but I think what Harry already said earlier on, that to give justice to what health professionals write, it's unreasonable to expect mostly one translator to do. So you do need to have some sort of a feedback loop and a quality checking mechanism, especially if it's for publication and especially if it's to be disseminated to large populations that they might rely on this information for making health decisions or legal decisions or whatever it is. And I think, organizations spend a lot of time, money and compliance on producing a brochure, a website or whatever it is. And then somehow they expect that either an automated translator or a real live translator will do it as well as, a whole committee. And that of course doesn't happen. So you do need to have, quality feedback loop built into whatever translations you produce.
Just one short example. A few years ago, I was sent about, I think, 150 words. They bad. So they sent me the translation and the original text. And the translation reflected exactly how the text was written. I mean, the translator couldn't do much about it. So that's where it becomes important that the source. And I said, the translator is right. They said she couldn't do anything. It was a woman, actually, I didn't know. And I said she couldn't do anything about it.
Rubbish in, rubbish out, hey?
Yeah.
Yeah, well, it's exactly, yeah.
And there's lots of terrible health content written in English. Awful health content written in English all over the place. And then, yeah, if you go and send that off to a translator, they're not going to be able to improve the quality of the content.
Can I just can I just give a plug? We just released a plain language writing e-learning. Anyway, it's about 2 hours long. I think that every quality assurance person should do that. Every person who's writing for the public in health, it's specific to health anyway. It's really practical. So I'd like show some stuff and then you practice doing it and then get some feedback. So yeah, I mean, it's just, I mean, the reason I did that, I was just trying to think about like practically, how do you get people to produce better stuff? And yeah, I mean, it's not easy, but I kind of figured if I could put everything together in 2 hours, so you could go through it and hopefully have a good idea about what you're aiming at in terms of like reducing the amount that you're asking the person to take in, not necessarily, you know, dumbing down your message. It's just like making the images and the layout and the words and the sentence length all work together to tell a sophisticated message, but that's easy to take in. So it's all about the person who's receiving it. How do we make it easy for them? You know, and those are all things that you can do.
Thank you, Jolene. We've got 4 minutes left. David, over to you for a few last words. And thank you so much for being part of this webinar. There's a whole heap of questions that we aren't going to be able to get to, but I'll just hand over to you for a few words.
Oh, look, I mean, I think that if we go back to where we were at the beginning, I think that things are changing. I wonder whether we need to develop some case studies or otherwise for sections of the health system that perhaps aren't taking a step in this direction yet. I think we've got to be really clear, and I think kind of points to what Julian was saying, that we've got to be really clear about what we're trying to communicate. What's the message that we're trying to get across? Because that's actually more important than the words that you were using. You know, if you start at that point, who are you talking to and what are you trying to tell them? Not what's the theoretical base behind it. Start there and then, you know, go.
Yeah, like what do you want to say and what do you want them to do?
Yeah. Simple but not easy. So over to you, Harry, to just wrap it all up before I say thank you for participation to everyone.
Thank you too. Well, my view is that COVID, because of its urgency, has provided a lot of opportunities to develop digital media and a large variety of digital media that hasn't been used before. So I think departments and other organizations have produced that. It's important to do a post-assessment of all that and draw conclusions in general for this specific subject, but also for the future, for other communication, health communication.
Wonderful. So on this note, I will thank Harry, Jillian and David for taking part, to Andrea for organizing as well. A lot of things to think about. I think, as we said, simple isn't easy, but we're going to continue to try. And on that note, thank you very much and have a good afternoon, everyone.
Thank you too.
Thank you.
Thank you.
Thank you, everyone. Lovely.
Thanks. Bye.
Bye.
Bye.